Good afternoon, everyone. I'm Dr. Anila Sarvani, oculoplastic surgeon. I first thank the scientific committee of APOS and especially Dr. Sujata ma'am, who is the guide behind me taking the oculoplasty. With this, I first start my presentation coming to dermoid cyst. What are the tips and tricks to prevent recurrence? So this is the overview of my presentation. Dermoid cysts are the most common orbital tumors which we encounter in our routine clinical practice. So what are these dermoid cysts? They are the benign choriostomas which arise from sequestration of ectoderm along the lines of embryonic fusion of mesodermal processes. They can stem from any of the sutural lines in the orbit, but the most common is the frontozygomatic suture. With the desquamation in the epithelial lining, and these cysts tend to enlarge over a period of time. So coming to a brief anatomy, this is the most common part where we get the dermoid cyst, followed by the zygomatico-temporal suture, zygomatico-maxillary suture, and the medial dermoid cysts they can arise from any of the sutures like frontomaxillary and nasomaxillary sutures. Coming to the this is not working. Excuse me. Laser pointer. Okay. Coming to the anatomy, here around the frontozygomatic suture, we should keep in mind about the frontal branch of the facial nerve, and also during the medial dissection, we should keep in mind about the supraorbital nerve, because if there any traction or resection of these nerves during the dissection may lead to impairment in later days. Coming to clinical presentation, the most common presentation is a painless subcutaneous mass along the sutural lines. In this patient, we can see that this is the most common type of presentation where the posterior margin is palpable. In such cases, any radiological this thing is not needed, but sometimes just to be on a safer side, we can go ahead with a CT scan. This is the second patient where we can see ptosis, which is restricting the field of vision, and also the cosmetic impairment. The third is proptosis. The patients here presenting in dermoid cysts with proptosis are usually late, because only with apparent proptosis, when the lesion is almost space occupying inside the orbit, when there is no other space to present, then the patient presents with proptosis. Sometimes here in this patient, we had this patient when his vision is almost 6/60, because the tumor is impinging on the optic nerve. His color vision was also deficit at the time of presentation. So the most common used imaging is computerized tomography, where we can usually see a well-defined hypodense cyst with a hyperdense lining. So coming to surgical management, excision biopsy is the treatment of choice. But here the most important is where the incision has to be given. If the mass is anterior to the frontozygomatic suture, usually the upper lid crease incision would suffice, which usually gets camouflaged. If the mass is superior to the frontozygomatic suture, suprabrow or infrabrow approach, and intraorbital, what I usually do is, instead of eyelid crease incision, I usually do lateral, in case the mass is in the lateral orbit in between the lateral rectus and the lateral rim, we usually do a lateral canthotomy with cantholysis. So here we did a upper lid crease incision in this patient. This second patient, this is a recurrent type of lesion where she has underwent surgery almost twice. Coming to other rare type of mass, this is a dumbbell or bilobed dermoids. These lesions, they transverse the bony sutures and expand into the adjacent chambers, and the meticulous dissection is of utmost importance to prevent recurrence. And here, this is a medial lesion in the nasoglobular region. Here in this patient, CT scan is a must, because we have to differentiate between an encephalocele and a dermoid cyst. So these are the postoperative pictures where we can see this is the lesion, and here we have given a incision where it is beautifully camouflaged into the eyebrows. Here we did a lateral canthotomy with cantholysis, and proptosis has come down. This is a almost 1 week postoperative patient, and even the incision is covered up. Coming to recurrent cysts, they form if any of the epidermal elements are not excised at the time of primary resection. But in some cases, complete excision is very difficult in case of giant or large dermoids, or the dermoids which are deep in the orbit or adjacent to the vital structures like optic nerve and superior orbital fissure. In such cases, if there is any rupture, piecemeal removal of the cyst wall must be done to prevent recurrence. So how to prevent? Appropriate incision is the most like the area of the incision should be in alignment with the where the mass is located and adequate area of the dissection. So the goal should be complete removal of the cyst wall and also intact excision if possible. So in case of rupture, thorough wash intraoperatively and careful removal of the contents. We usually what if in case of there is any intraoperative rupture, the all the content should be removed meticulously and a thorough betadine wash should be done. And it is always better to use microscope in case of rupture to ensure adequate removal of the cyst wall and its contents. With this, I conclude my seminar and I thank Dr. Sujata ma'am, who is my teacher, for giving me this opportunity.
Very good presentation, Anila. One little point I wanted to mention is that you can have deeper dermoids which are in the orbit which cause proptosis, and the more anterior ones present at a younger age because there are more evident. And if you do rupture, which happens often because the wall is thin, you could use blue to stain the entire dermoid, so that you're sure that you've removed the entire thing. And nowadays there is also another method of injecting sclerosant into the dermoid without doing a surgical excision, where there will be no scar left. Good presentation, well done.